So if we remember the musculature that we spoke about in the previous lecture, we remember here, which we can see those from anterior to posterior. Here we can see the piece of intestine, piece of gastrointestinal viscera. And from anterior to posterior, we can see the skin, we can see those 3 layers of muscles, we can see external oblique, we can see internal oblique, and we can see transversus abdominis. And then we mentioned a thin membrane called transversalis fascia. And for the inguinal canal, this is a really important membrane. So please remember, we have external, internal oblique, transversus abdominis, and transversalis fascia in that order, from anterior to posterior, or from deep to superficial. And here we can see them with some details on the side of the screen. Here we can see external obliques aponeurosis. We can see external oblique, the fibers running down in this direction. We can see its fibers running towards the linea alba in the midline. We can also see that we've got a slight defect here in external obliques aponeurosis. We have a slight defect. And that defect, this opening, is known as the superficial inguinal ring. So here we've got external obliques aponeurosis, and I can just make out a line here, and this is external oblique aponeurosis with a defect in, and this is the superficial inguinal ring. It's within external obliques aponeurosis, and it's really important because it allows the spermatic cord, or the round ligament of the uterus in the female, to leave the abdomen. So it allows these structures to pass away from the abdomen and go to the labia majora in the female, or go to the scrotum in the male. We can see we've got the superficial inguinal ring down here. We also have a deep inguinal ring, and we'll explore that later on. These muscles which I spoke about previously, they still exist in this inguinal region, and they go on to form what's known as the inguinal canal. This is a canal that has 4 boundaries. It has an anterior wall, which we'll look at, and for now we can say that is the external oblique aponeurosis. We can see that here, the anterior boundary. We'll explore it later and see that other structures also form the anterior boundary. It has a posterior wall, and this is where we need to remember transversalis fascia. It has a floor, which is the inguinal ligament. We can see that here, the inguinal ligament. And then it has a roof, and this is really important because the roof is formed from some arching fibers that start from the inguinal ligament and then run medially and posteriorly to attach to the pubic tubercle. And by doing that, they create a channel that allows the spermatic cord, or the round ligament of the uterus, to pass through. So it's particularly complicated, this area, so it's important to try and listen carefully and try and appreciate the nuances of this arrangement. So this diagram, which we can see, tries to explain the arrangement of the inguinal canal. And like I say, it is particularly complicated. But let's just try and remind ourselves of some basic information that we already know. We know we have 3 layers of muscles. We've got external oblique, which we can see here. We've got internal oblique, and then deepest we've got transversus abdominis. Now it's important we remember those structures, those muscle layers. We can also see that we have a whole series of structures here which are starting within the abdomen. And this is really quite clear if you imagine the male, where the testes of the male are positioned outside of the abdominal cavity. They're located within the scrotum. And here we can see we've got the testes. But during development, these testes and the ovaries originated on the posterior abdominal wall. But with development, they migrated down the posterior abdominal wall and penetrated the anterior abdominal wall to reside in the scrotum. The ovaries didn't. The ovaries stayed in the pelvis, which we'll see as we go on to the pelvis in future lectures. But the testes migrated through the anterior abdominal wall. So as they migrated through the anterior abdominal wall, they took with them the layers of the muscles that form the anterior abdominal wall. So if we look in more detail, we can see that these structures that are passing down in this direction, they head towards the anterior abdominal wall. And then they pass through the wall to exit via the superficial inguinal ring, which we can see here. And on this side of the screen, we can see that I've put in some details which help to work out, help to explain the arrangement and the formation of the inguinal canal. So, what we can see is the free edge of external oblique aponeurosis. External oblique, we see muscle here, is running down in this direction. Remember, it's running downwards and forwards. And its muscle, it runs to where we've got the anterior superior iliac spine here, and it runs all the way down to where the pubic tubercle is here. And at the free edge, so this boundary here, this inferior boundary of external oblique aponeurosis, is the inguinal ligament, a sheet of muscle that is coming down. It gives rise to its aponeurosis, and where it attaches to the pubic tubercle and the anterior superior iliac spine, it kind of turns back on itself to create a gutter, and that is the inguinal ligament. What we can see are numerous layers. Here we've got transversalis fascia, and here again we can see transverse abdominis, and then we can see internal oblique. And what we can see is, if we imagine this testes has started up here, the testes has migrated down through these layers. It's migrated down through these layers, so it's passed down in this direction. So, as it's passed down, it's taken a layer of transversalis fascia with it. Okay, so transversalis fascia is lining the posterior abdominal wall, and as the testes gone through it, it's taken a layer with it. So it's pushed through this membrane, much like when you put your finger inside a balloon. It takes a layer of that balloon covering with it, and that's what's happened. It's passed all the way through with a layer of transversalis fascia. We can also see that it's gone underneath this muscle here. And this muscle, if we follow it back, is transverse abdominis. Importantly, transverse abdominis runs horizontal. From the inguinal ligament, it runs horizontally across. So the testes hasn't actually penetrated transverse abdominis, like it passes through transversalis fascia, taking a layer with it. It actually runs underneath transversus abdominis muscle. And that's where we can see transverse abdominis arching over, forming the roof of the inguinal ligament. We can also see that we have this muscle layer here. This is internal oblique. And we can see actually that the testes has taken with it a layer of internal oblique. So it actually went through, just like transversalis fascia, it went through internal oblique, taking a layer with it. Also, we can see part of internal oblique running over the spermatic cord. So we have a second structure forming its roof. We have transversus abdominis here, and now we have internal oblique. These structures are forming the roof. If we look anterior to the spermatic cord, which contains the tail of the testes with vas deferens and various blood vessels within it, we can see that anterior to it, we actually have external oblique aponeurosis and internal oblique muscle. So that forms the anterior wall. The floor, we said, is the inguinal ligament. Anteriorly, we've got external oblique aponeurosis and internal oblique aponeurosis. Over the roof, we've got transverse abdominis and we've got internal oblique. And then posteriorly, we can see we have this thin membrane, which the testes penetrated as they passed through, and that's transversalis fascia, forming the posterior boundary. Now, these structures vary subtly as we're going from the lateral to the medial aspect of the inguinal canal, and they vary depending on exactly where you are in the inguinal canal. But that paints a general picture that is probably sufficient for the majority of you to understand that we have these layers that the testes passes through. I haven't mentioned the deep inguinal ring, but we can see the deep inguinal ring is here. And that really is where the testes have penetrated through transversalis fascia to enter into the canal. So we can see the deep inguinal ring is starting here. Importantly, we have inferior epigastric vessels lying medial to it. So the deep inguinal ring runs lateral. The structures are in the deep inguinal ring, run lateral to these epigastric blood vessels. That's really important when you're using an ultrasound to locate inguinal hernias. And then the deep inguinal ring containing the spermatic cord or the round ligament of the uterus passes out through this defect in external oblique, and that is the superficial inguinal ring. And here we can see the testes. One more detail on the posterior wall. I mentioned it's mostly formed by transversalis fascia, but we can also see really clearly in this diagram the conjoint tendon. The conjoint tendon is really important. It lies directly posterior to the superficial inguinal ring, and it's formed by internal oblique aponeurosis and transverse abdominis aponeurosis merging together, where these two muscles merge together to attach onto the pubic tubercle. And this conjoint tendon is really important as it helps to strengthen the inguinal canal directly posterior to the superficial inguinal ring. If you can imagine that we've got this slit-like opening in external oblique aponeurosis, the superficial inguinal ring, then this is a potential site of weakness. So increases in intra-abdominal pressure can push against this weakness and it may herniate. The conjoint tendon reinforces this posterior boundary of the superficial inguinal ring, helping to prevent herniation. So here we have a nice diagram showing an overview of the inguinal canal, but I appreciate this region is particularly tricky.